Okay, this is a very broad topic, but I just want to highlight the important parts of degenerative lumbar spine pathology. I mean, as you all know, lower back pain is a big burden on all systems. I mean, just from the patient load to patient management, what we must do. I mean, clearly, early on, you have to decide, is this mechanical back pain or is this back pain with neurological compromise or neurological injury? And I mean, through this touch, I'll hopefully give you guys a simplified approach to assessing a patient with lumbar spine pathology, and also deciding who needs surgery and who doesn't. I think that's the mainstay. All your other literature and stuff you can read. I focus my touch on giving a more practical approach to conditions. So you can't start talking about the lumbar spine without knowing the anatomy. And just looking at the picture on the far left, the axial, I mean, that shows you the close relationship of the neural structures to, in the front, the disc, in the back, the bone or the facet joints, but also don't forget there's flavum overlying the bone. And all of this close relationship is what actually causes compression to the neural structures if there's a problem in that area. Looking at the picture in the middle, that's just showing you a sagittal and the relationship of how the nerves come out. So remember, in the cervical spine, because there's 8 cervical nerves, you know, the one starts and comes over on the top. That normalizes in the lumbar spine in that at L1, L2, the nerve root that's coming out is L1. So you can say that that nerve root, you name it according to the vertebra above, or when you're looking at that functional spinal unit. So you're looking at L1, L2, the exiting nerve root will be L1, and then the traversing of the nerve root going past will be L2 in the close proximity. The picture on the right is just another representation of this scenario and the proximity of all the structures to each other. So there's not a lot of space to allow for, if there's any pathology, the pathology normally results in compression of the neural structures. Quick recap, you have to know myotomes and dermatomes because this is how you localize the lesion. And I'm going to repeat this a couple of times during this TUT. The best spinal patient is one where the history, the clinical picture, and the radiology all line up. So you can't assess that if you don't know the dermatomes, because you have to elicit from the patient's history which dermatome. When a patient says, this is going down my leg, that's not enough. You actually have to tease it out of the patient and ask them to point with one finger. Remember, up to the ankle, L4. The top of the foot is L5, and particularly the big toe is L5, all right? L5 also goes around to the anterior part, so distal to the metatarsal heads, that's all L5, so it creeps over and goes around the front, whereas S1 is the metatarsal heads and everything working behind, all the way around to the heel. So you have to get this information from the history before you can proceed. There are some cases where patients will give you a broader picture, and that I'm going to talk about when we're looking at specifically spinal stenosis. But if you're looking for, and you're trying to find out this is a foraminal problem or rather it's a radicular problem, a clear understanding of the dermatomes is essential. Myotomes, as you know, I mean, written there, L2, hip flexors. You pick the strongest myotome that's relevant to that region. Hip flexors, L2, L3 extension, L4, ankle dorsiflexion, L5, long toe extensors, and S1, ankle plantar flexion. So that helps you already map. And by just your history and your examination, you already know where you expect the lesion to be. Now, your MRI either confirms what you're suspecting, and in that patient, that's what we call that gold. That's spinal gold, because that patient, everything is lining up, and you know if you operate on this patient, the chances of getting a good result are high. Patients where things don't line up, stay away from them, or rather stay away from them surgically, because you want to operate where you know that you're going to make an improvement to the condition. This is just a list showing that, you know, back pain has got lots of causes. There's spinal causes, and just to highlight there, the listhesis, stenosis, fracture, infection, and inflammatory. Don't forget tumors. In our unit, most of our tumors go to neurosurgeons, but I mean, as a spinal surgeon, you have to be aware of tumors, and you have to know the different techniques that or the different causes related to tumors and how to identify and manage them further. Endocrine causes we'll always forget, because, you know, remember, osteoporosis will lead to further compromise of the spinal stability. You can even get the fractures. So never forget to include endocrine as a cause of your lower back pain. The question is it something you can operate or not? That will get you later. And don't forget sickle cell disease. This list just further emphasizes multiple other causes of lower back pain. That is extraspinal. So remember, all visceral organs can cause pain that's presumed to be felt from the back. You know, renal stones, a duodenal ulcer, don't get caught out, especially those, you know, retroperitoneal ones, and that part of the duodenum that's running retroperitoneally, that can catch you out. With a patient with an aortic aneurysm, even an abdominal aorta aneurysm can manifest as that. Biliary colic, always look for gynecological causes in the patient that doesn't fit the profile. Sickle cell crisis can manifest as with spinal. When you're looking at drugs specifically, NSAIDs will give you a peptic ulcer, and your steroids, by leading to osteoporosis, can cause spinal fractures. Looking at musculoskeletal, don't get caught out by the hip. Okay, lots of patients will point to, I've got back pain, but they're actually pointing to the hip. And just a rule of thumb, most back patients don't use crutches. When you see a back patient coming into your room and they're on crutches, look for the hip. And a quick survey of the hip is a quick hip roll to see if there's any pain, but a proper assessment of the hip, internal and external rotation. If those are normal, then it's most likely from the back. But if there's any abnormality there, then you suspect for a hip joint. Some MRIs or some private radiologists, they routinely include the hip joints in their lumbar series, because they've also been caught out where they've only commented on the lumbar spine and missed hip pathology. In our x-rays of Grooteskiel, I've seen sometimes you're lucky enough to get just the top of the joint, you know, but if you're worried, rather do a dedicated AP pelvis to look for any hip joint. Always look out for SIJ or, you know, sacroiliitis or any type of, in your ankylosing spondylitis. Just any pathology around that area can manifest as a spinal problem. Something that's not on this list is something called piriformis syndrome. Prof. Dunn doesn't really believe in it much, but however, when you are struggling to find a diagnosis and the patient has got signs of sciatic nerve compromise or compression, but that's not in the spine, they can get caught just along the piriformis. Remember, there's multiple variations of how the piriformis muscle run and where the sciatic nerve comes over, either over or under. And there can be some compression in that area. And always beware of the psychogenic or the crazy patients. Red flags, we always talk about this. You've been hearing this for a long time. Red flags, night pain is always a red flag. You're worried about tumor or cancer. Fever, unexplained weight loss, you're looking at things like TB. Bladder and bowel dysfunction. So unless this, I mean, if you're looking at either caudoquina or conus medullaris syndrome, and if any of this is present, it's a red flag that you need to act immediately to sort it out. A history of carcinoma or family history of carcinoma, always worry, because we know cancer likes to spread to the spine, and you always have to be aware. If there's a history of carcinoma, look deeper for the cause of this pain. Ill health and presence of other medical illnesses, like you've got your patient who we've got now with pneumonia, and they've been in the hospital with pneumonia. They can get infections, spinal infections. Progressive neurological deficit is something that I'll talk about later, but that's showing you that there's something compressing the nerve, so you need to act quicker. So remember, the red flags are there for you to, when you see a patient in the clinic, you decide, is this something that I need to act urgently? Is this something that can wait while I'm investigating? Or is this something that I can send to the day hospital as mechanical back pain? If any of these things are present, the red flags, it's something that you need to investigate more urgently, and an MRI is indicated in most of these cases. The ones with cauda-equina, disturbed gait, saddle anesthesia, that's where you need to act. I mean, that's immediately. Another important thing, patients younger than the age of 20 are not supposed to have back pain. So you look for the cause. If they, obviously there's that malingering, there's that child trying to get off tests, but usually you have to actively exclude pathology. And ages more than 55, we say that that's an appropriate age, so that is where you expect to find spinal pathology. So look deeper into that as well. So all spinal surgery is aimed at relieving neural compression, all right? You guys must be clear. That is the gold standard of indications. You want to relieve neural compression. So it can be compression of the roots, or it can be compression of the thecal sac. So looking at where this compression occurs, the first area you have to talk about is foraminal. So my sequence when I'm looking at an MRI is to look at sagittal first, and the sagittal I'm looking at midline. And then I scroll from left to right, looking at the different foramina. Now, foraminal compression, as demonstrated by that picture with the arrow on the sagittal, you can see, first let's look at the normal area. Normal area, you've got the nerve root is black in the center, and then around it you've got the fat and the CSF surrounding the nerve root. In an area where there's foraminal compression, that disc or whatever pathology is squashing that foramina, that you can't see any neural structures, or it actually decreases the fluid around the fluid and the fat around the nerve root. All right. So a foraminal problem will present with radicular symptoms. This means that it is unilateral, okay, because it's affecting that one side. It will follow a typical dermatomal distribution. Now, I've seen where you guys get caught out. You like to say, oh, this is an alpha-5 pathology, or alpha-5. You describe it broadly as saying in the region that it is. For accurate spinal nomenclature and description, an alpha-5 disc, foraminal disc, will cause compression of the L4 nerve root. So you have to be specific as to say which nerve root is going to be compressed. Okay, it's not going to compress L4 and L5 with the foraminal disc. It'll compress only the L4 nerve root. And you mustn't get mixed up between describing the level and describing the nerve root that's being compressed. And that's what Prof. Dan also hammers you guys on, is when you say L4-5, that's the level. It's not the actual root that's being affected. Also, this patient will present with nerve tension signs. So if it's in the lower nerves, the more caudal nerves, you'll get a positive straight leg raise. So remember, this is a range. So An early positive straight leg, that's at 20 degrees, is showing that this nerve is really tight and it's really tense. If you get a normal person straight leg raise at 70, 80, that's normal. You're supposed to feel that pain and that tension because, I mean, most of us at our ages probably can't get beyond 70 degrees when you're doing a straight leg raise. So remember, it's not just looking at is the pain, it's when the pain starts. You have to quantify. There's a positive straight leg raise at 20 degrees, okay? The other nerve tension signs is the femoral stretch. You lie the patient prone, and this is to assess L1, L2, and sometimes L3. You lie the patient prone, and by then extending that hip or extending that leg backwards, it replicates that pain going down. So that's a sign of more cephalad lumbar pathology. So just to highlight and just recap there, foraminal, radicular symptoms and demonstrated by dermatomal, myotomal, and specific nerve tension signs. This is a concept that I'm sure when I was a junior trauma registrar, I did not understand at all. This lateral recess. A lot of spine surgeons talk about it. Where is this lateral recess? We'll start with the picture on the right, the drawn picture. It's showing you that the lateral recess is that orange area just before you go out in the neural foramina, okay? It's the area that's underlying where the facet joint occurs, and it's also some of the pars is overlying that lateral recess. Now, if you look at the MRI sagittal, that arrow is pointing to the lateral recess. So if there's compression in this lateral recess, it's not going to hit the exiting nerve root because by that time, the nerve root in that segment has already come out above it. A disc that's protruding in the lateral recess will most likely hit the traversing nerve root. Remember, with anatomy, the nerve roots come out and they go under the pedicles. And then you've got pedicle, nerve root, and then disc. So that's if you're looking at it from top to bottom. If a disc herniation is in the lateral recess, it can only hit the traversing nerve root. Because if you look at the thecal sac and how it lies, as demonstrated by the drawn out picture, that L5 nerve root has already come out. How it lies in the spinal cord, it's already getting ready to come out of the L5S1 area. So it's already lateralized, and that's where it gets caught. So with lateral recess stenosis or lateral recess compression, it can be unilateral, and in that case, it will cause radicular symptoms and signs, but it can also be, in the combined picture, which I'll get to, it can be very broad where you've got bilateral narrowing or stenosis of the lateral recess area. This is a very, very important concept to understand. As I said, when I was a junior, I wasn't aware that the lateral recess existed, but it's an area that it's most of the time with these degenerative processes, an area that's compromised quite a lot. I'll move forward and then I'll show you guys more about the lateral recess and how it causes problems. When you're looking at the facets themselves, facets, remember, are lined with cartilage, which means that they also go through that normal arthritic degeneration. They manifest with a deep type of ache, so a fatogenic type of pain, and these osteophytes and hypertrophy. This may lead to compression, and normally the facets, when the facets are hypertrophied, they cause further compression of the lateral recess and manifest with this pathology of, bilateral lateral recess compression that's going down, and it's normally affecting the traversing root to that level. So this is what we normally get in our advanced degenerative process. You get multi-level areas of compression, and it's usually a central spinal stenosis. This central stenosis is caused by, firstly, in the front, it's caused by the disc. So the disc has a broad-based disc bulge, because as the disc undergoes degradation and it goes degeneration, it loses its integrity and it starts bulging out. This bulging can then be of all the different types of disc herniations. This bulging further adds to narrowing of the spinal canal itself. All right, so we'll go to the illustration at the top. This spinal stenosis is further complicated by, at the back, the facet joints, which is the bony component, because as the facets undergo their arthritic process, they get hypertrophy to try and stabilize it, and then they further compromise and narrow the lateral recess. Then the flavum also undergoes hypertrophy, and in, by that regard, further causing more spinal stenosis. So in spinal stenosis, you're going to get a more wider distribution of nerves. The patients present with a bilateral buttock type of pain, or they'll say the pain goes down both legs. And they'll also have neurogenic claudication. This neurogenic claudication is manifested by a decreased walking distance. And the difference between that and vascular, this one, as soon as they sit down and flex the spine, they get immediate relief. So remember, with a vascular path, you're going to get the other clinical manifestations of vascular pathology, the skin changes, etc. With your neurogenic claudication, the patient will tell you, but when I walk far, I get this bilateral calf type of pain. It gets better when I sit down. The grannies will tell you about their shopping trolley sign. That is when they are when they go to the shops, they like to lean forward because it opens up the spinal canal. Another way of looking at it, they'll tell you that they find it's easier to walk up the stairs than down the stairs, because when you're walking up, you're flexing forward. When you're walking down the stairs, you're hyperextending and you're closing down that spinal canal. So just to recap, foraminal stenosis, radicular, it's dermatomal, it's myotomal, and central or spinal stenosis is a wider distribution, because you can see in that illustration, all those nerve roots are clumped up. If you're looking at the MRI images at the bottom, you can see that spinal canal is very narrow. It's getting compressed in the front and in the back. And when you're looking at the actual neural elements in there, those little small dots are the nerve roots within the thecal sac. As the stenosis increases in size, so the shape of the spinal canal changes. It goes from circular, and then it starts becoming trefoil or bikini shape. And with that, with the worst type of stenosis, having very little CSF around the nerve roots, and all the nerve roots being clumped in the top part of that area. So this is the hallmark of our talk, because remember, spine surgeons can only assist with surgical causes of lumbar pathology. So degenerative disc disease, disc herniations, spinal stenosis, spondylolisthesis, and surgical imbalance. These are the only times when we can actually intervene and do something from an orthopedic point of view, and more specifically from a spinal surgery point of view. All the other conditions are for non-surgical management, and we shouldn't even be seeing them in our clinic. We need to, if they don't have one of these, they need to go somewhere else to get sorted out, either pain clinic or any other type of management, but definitely not for the orthopedic clinic, and definitely not for the spine clinic or Prof. Dunn's clinic, because these are the patients we can only help these patients surgically. Looking at disc degeneration itself, it usually begins in the third decade of life. It's characterized by a decline in the proteoglycan, and with resultant loss of hydration. That's why on an MRI, the normal disc is brighter because it's got on a T2 weighted, because it's got fluid in it. And as it degenerates, it becomes darker and blacker. We're talking about the disc itself, because it's losing all the water content in it. And as it degenerates, it causes loss of disc space height. That loss of disc space height then further causes foraminal stenosis. So the foramina becomes smaller because of that. And it can also alter that segmental spinal biomechanics. And that's illustrated by those two images, the histological specimens, that, you know, the disc, you can see it's nice and clear. As it degenerates, it becomes quite useless in its function. And remember, the disc's major function, we can just loosely put it as a shock absorber. It can tolerate all the forces that are going through your spinal column, go through those discs. And that's why the discs at the bottom, because they are undergoing the most load, they're the ones that typically degenerate first. This is an entity that you must know about, the lumbar disc herniation. Its peak incidence is in the 4th and 5th decades of life. Remember, the ones that we see, it's quite a small percentage who actually become very symptomatic. They always say that you can do an MRI of majority of 40-year-olds and you'll find there is some disc herniation. But the question is, which ones are symptomatic? And in spine surgery, that's why we want to make sure that the history and the clinical lines up, and those are the ones who need something done for them. But also remember, only up to 4% of these patients are actual surgical candidates. You know, so majority of them don't need surgery, and majority of them shouldn't be getting surgery. And as I said earlier, the caudal or the distal segments are usually more affected, with L5, S1 being more affected than L4, L5. The natural history of the disc herniation, 90% of patients will experience symptomatic improvement without surgery. And then this will normally happen within 3 months of symptom onset. Most of the disc will resorb and diminish in size over time. So the typical disc herniation is usually associated with an inciting event. I picked up something heavy. The back pain can vary from just small back pain to debilitating back pain where they can't get out of bed. This pain usually follows a dermatomal distribution, you know, along the affected route. That's why it's very important. I'm stressing this again. Know your dermatomes. Try and find out, where does the pain go to? Look for other associated motor fallout. Long-standing compression of a nerve root will result in motor fallout. And that is one of the relative indications for surgery. Sciatica, you know, it's a very broad term. Remember, it's a descriptive term. It's not a diagnosis. It's just telling you that the nerve is being compressed. But it's very sensitive to show you sciatica combined with the clinical finding of a straight leg raise is very specific to show that, and in a patient where the x-rays are normal and everything else is sort of normal before you got an MRI, those things are leading already to a lumbar disc herniation. So just to put that in context, a 40-year-old patient gives you a history that picked up something heavy. They then say after they picked up something heavy, they had debilitating pain going down to the big foot. You test them, they've got a sensory alteration down the L5 dermatome. Myotome is still intact. You do an x-ray, you don't see anything major on the AP and the lateral, even on the obliques. That patient most likely has a lumbar disc herniation. The next question is, what should you do for this patient? There's a lot of literature written out. If it's just pain and with no motor fallout, you can treat this as a lumbar disc herniation without getting an MRI. especially in our resource limited state service. That will be a first. This is a first presentation, acute presentation. You've done clinical, you've done your history of clinical examination, and you've done your x-rays, and you don't see anything there. You can manage that patient without an MRI and treat them as such, you know. But beware for the patient who's got bowel and bladder dysfunction. Although this is rare, this changes everything. This is a red flag. Let's push them into that MRI algorithm. Urgent management. Sort this out now. Okay. Looking at the different types of disc herniation. So you know you've got your nucleus in the middle and your annulus around. Good analogies like a wheel, a tire, and then inside the tire, the black part of the tire is the actual annulus. Then the rim is the actual nucleosus pulposus. So the different degrees of disc herniation can just have a degeneration, maybe a small tear, you know, with still an intact posterior annulus. This can then advance further as this nucleus herniates through the annulus and it's moving through so the annulus are like fibers that are going concentrically around. So this nucleus material, it's like a jelly, like more like maybe crab meat that you can describe. It starts pushing forward through. And as it's thinning this annulus, it then moves on further to become an extrusion. Okay, extrusion is when there's no more annulus. I've put in the slide on the right because there's a concept you guys must understand. The difference between protrusion and extrusion. In a protrusion, the head is less than the neck, than the diameter of that segment. So the neck where it's coming through, the head is less than the size of the neck. In an extrusion, the head is far wider than the actual neck when it's coming through, meaning that there can be some little remnants of annulus on the back, or it can be the worst type where it's now the nucleosus has herniated through the annulus and you've got exposed nuclear or nucleosus pulposus material. The sequestration just means that that disc fragment that has herniated out is no longer in continuum with the actual disc in the disc space. So there's a separation between the herniated fragment and the actual main disc. That's your sequestrated disc. Chu et al. In 2015 looked at the natural progression of a disc. And they found that the rate of spontaneous regression was 96% for disc sequestrations. It came down to 70% for extrusions, 41% for protrusions, and 13% for bulging discs. So that's just saying that the worse the disc herniation is in the sense that it's not covered by the annulus, the higher the chance of it being resorbed. Now, I haven't gone into how you're assessing this resorption. So you can look at, it takes a lot longer for the MRI picture to change, and there was varying within the study, there was varying amounts of resorption over time, but they looked at up to between 1 and 2 years, and most of the ones in the sequestrations had resolved. Now, when you're looking at time, you look at either MRI features of resorption, or for us, what's more relevant is the clinical picture of resorption. Majority of the patients will get better clinically, that is, get back to life without surgery. Looking at why this happens, and the most accepted theory is that with the sequestrated disc, there's no annulus protecting, or there's no annulus covering that nucleosis, and that allows phagocytes and macrophages to adhere to that area and then cause reduction via immunohistological process. Also, I mean, there's a lot of blood flow. They say it allows that this disc material is also closer to all the capillaries and all the inflammatory mediators as provided by the epidural vessels. So that allows the body to attack and resorb the disc material a lot quicker. Okay, so that's why in your sequestrated disc and your extruded disc, they have a higher resorption rate. However, be aware that the sequestrated and the extruded discs are also the most painful. Because they affect a broader area, and that initial inflammatory process irritates the nerve, and those patients can be in severe pain. You know, so you've got that scenario where the one that's going to resorb the best is also the one that's going to present the worst to you. But that's why you need to give all these patients time to allow the process of this phagocytotic and immunohistological regression to occur. They also postulate that as this exposed disc dehydrates, it shrinks back into the disc space. And they also said this last theory of this mechanical retraction is still a theory, but there's no one who's proved that this disc also resorbs. Now we're looking at the ones that are either the low disc herniations where there's still quite a lot of intact posterior annulus around the discs. Non-surgical treatment is the mainstay of disc herniations. As I said, your patient comes in, you will try not to operate because you'll tell them majority of the disc will get better. Okay. You will then individualize the treatment. The reason why I say that is the patient comes in, they've got a disc herniation. You know it's going to get better. They mustn't be, you give them bed rest, but not more than 2 days. You give them good analgesia, paracetamol, you can give them an opioid-like, and then you can give them an NSAID is mandatory. Brufen, that's the older stuff, but you can give them your coxibs. There's a newer one now, Arcoxia. Arcoxia is fantastic. It's a once-a-day dose, and you can give up to 120 milligrams, and it's very effective in decreasing the inflammation in that area. Muscle relaxants, you can give them. So you can give them a benzo just to relax them and calm them. But you tell them you do not stay in bed for longer than 2 days. After 2 days, they must get up and start going. Then you watch their progress. You watch this progress over 6 weeks. Okay? This progress you're watching over 6 weeks to make sure that you'll see them at maybe 2 weeks to see how they're doing. Is it improving? Then you know you're doing well down the treatment line of non-operative. And by 6 weeks, they'll tell you they're asymptomatic. Now, adding to that medical component is physiotherapy. There are some guys who say, you know, physiotherapy is actually doing the wrong thing, but the research has shown that by keeping them active and keeping the spine mobile, you're actually sort of putting some neuromobilization and some neuromodulation by allowing that to occur. So physiotherapy is you're also strengthening the core musculature around, and you're allowing that spine to sort of carry and maintain its physiological load. Now, this patient, when I said individualized care, is now what do you do with the patient that doesn't get better? That patient who then comes back to you after a week and says, Doc, I can't get out of bed. I can't function at all. That is a patient that you need to look deeper into, because that is showing that this is not behaving in the routine. This is that 10 or 20% that may not get better. So then you can decide, I'm going to get an MRI to see what's going on, you know? Or you can find the high performance athlete who's saying they cannot afford to be, you know, in this non-functioning state. You know, they need to be back on it. So that type of individualized care and assessment, you know, then you can say to the patient, okay, I'll offer you something that's not surgery, that's something we don't do in the state, some type of steroid injection. Now that can vary from, you know, an epidural caudal block where you're just bathing all the nerves around it. It can be a specific injection to the neural foramina, that's specific, localized, so it ranges. It can be to the facets, specifically to that facet that you're thinking is causing it. You know, so your injection of steroids and anti-inflammatory into that area is to try and buy you time for that patient who says, I need to get back to work, I can't function, or the patient who's showing that they're not responding to the normal treatment modalities. And that injection varies from a caudal where you're bathing that whole area to a specific foraminal injection where you're injecting to around that specific nerve root. And with that foraminal, they normally tell you they're getting better, so you inject them and tell them walk around. And that can also serve as a diagnostic type of procedure where you've given the injection, you see them an hour later, and if they tell you their pain's better, you know that that's confirming that you're in that right level. And the actual techniques, how you find your level, I mean, your caudal, you just go straight and you're aiming to bathe that whole lumbar, that whole caudal area in your lignocaine and your steroid. With your specific foraminal injections, you use contrast to identify your area. There's certain techniques that you are seeing where you are to confirm that you're in the right place. And then you inject, and as I said, you wait and see the patient's response. Other oral steroids, we are against them. They've got more disadvantages than advantages. Now, looking at stuff like acupuncture and chiropractor, I, as a spinal surgeon, don't know enough to comment about them. But you get to a point with the spinal patients where you don't want to operate and you're looking for options and you're looking for ways of managing this patient. And I always say to the patient, if it works for you, go for it. If you've seen that the acupuncture has helped you, go try it out, and I'm happy not to operate you. If you've seen that the chiro has helped you, go out and try it. And if it's helping, I'm not going to say don't do it, because I know that when I touch them, that's the last option. There's no, I'm going to go spinal surgeon and then go back to the chiropractor. We are at the last part of the chain. And if anything else can help, and whatever fairy dust or whatever else that they want to use is helping them, yes, because in spinal surgery, you never want to operate unless you really have to. Surgery is always after you've exhausted all non-surgical avenues. Traction, they'll talk about, but it hasn't been validated for lumbar disc herniation. So I've already spoken about this slide. I said you want to look at 6 weeks, but you don't want to go beyond 3 to 4 months. The reason for this is by that stage, the disc starts to become hard and starts to become difficult to actually get out. A successful discectomy, you go in, you pull out a nice blob of crab meat, and you know the patient's going to do well. The ones that have gone, those chronic disc herniations, they go from being nice and soft to being hard, and they're difficult. And after them, you don't feel that same amount of satisfaction. And in your head, you're always worried, is this patient going to get better or not? Looking at our indications, absolute chordoequina, which is rare. Another absolute, progressive neurological deficit. I want to add motor fallout. I've got motor fallout in a lumbar segment. It's showing me that the compression has been there for a long time, and that compression is significant enough to cause loss of motor function. A simplistic way of looking at it is, as the compression goes, when it starts off, it's an irritation, it causes this pain and the paresthesia. As it gets more, it starts affecting the sensory component. I can't feel, my whole foot is numb. As the compression gets more in size or longer in duration, it starts affecting the motor fibers. And we know once you've got motor loss, you're starting to say that nerve's function is being quite significantly compromised, and you need to get that compression off as soon as possible. Relative indications, as I've spoken about, intractable radicular pain. The high functioning patient who doesn't want or cannot afford to miss and go through the 6 weeks of unknown and is quite in severe pain. Failure of non-surgical treatment is a relative indication. Recurrence, I saw a patient who you've managed non-operatively, and then they successfully completed non-operative management, but then they come back again. So a recurrent type of disc. You can't do the same thing because probably the tear is still through the same area, and that patient, you can make a strong case for operation. So from the surgical procedures, a discectomy remains the gold standard of care. And you must always tell the patients you're doing the operation to get rid of the leg pain. Spinal surgery comes with its own potential problems depending on how much you have to do to get to that disc. Looking at the techniques that we have to get to the disc. So you can also picture it. You've got a large central bulging disc. You can't go and take it out from one side, and you can't take it all out because its annulus is still intact, but this disc is causing compression of and spinal stenosis in that area. So that patient will benefit from a laminectomy. That is demonstrated by the picture in the middle. With the laminectomy, you're taking away all the midline structures and the lamina. You are basically creating more space for the neural structures. An important thing is this. The reason why laminectomy works is because the lumbar spine is lordotic in nature. So by taking out that lamina, because of that posture, the thecal sac will drift backwards and therefore get more space for the neural structures. Now, a discectomy is a good way to get to the lateral recess disc, a disc in the lateral recess, a foraminal disc, and an extraforaminal disc. How you get to this, to do this discectomy, okay? You can do a laminotomy. So ectomy, you're taking away all the posterior spinous, the posterior elements, so you're taking away spinous processes and both lamina on either side. And laminotomy, you're making a hole in the lamina. Now, depending where you're thinking this disc is, you can make a more midline laminotomy, identify your dural structures, and then go around, or not your thecal sac, and then go around to the disc to get there. You can approach this from lateral, where you are doing, to try to get into that foraminal disc, or the extraforaminal. In terms of surgical approaches, we know that a midline approach is the most destructive, because there I need to detach the muscles from the spinous processes all the way down to the lamina. And so this is quite destructive. If I've got an extraforaminal disc, I can do a Wiltse type of approach. This is where you're working in between. It's an intermuscular plane. It's lateral to the spinous processes. And if you get your planes right, you literally don't have to do any cutting. You open an intermuscular plane, and then you down to the lateral side. Normally down, you land normally around the facets and the transverse processes, and then you can identify where your disc is, or where your landmarks are, and where you need to be. So obviously now everyone's trying to do minimally invasive surgery. This is facilitated by stuff like, there's tube systems where you put your K-wires to find the level that you want to be, and then you literally use tubes to sequentially dilate that area to allow for you to see and create a working channel. So the tube systems are designed for what you call the true microdiscectomy. You know, they're nice in that you go and you land directly where you want to be, and then you just dilate that area up without causing all that damage to the midline structures. And endoscopic is something that we should talk about because it's the new in thing. However, a lot of people will talk to you about endoscopic. You must understand it's got a very limited application and requires strict patient selection. That is because you can only manage a very narrow spectrum of discectomies using endoscopic procedures. And the patient profile also has to fit a special select group. So in the right indication, in the right patient group, you can get good results. However, you have to have a clear and good understanding of your anatomy, because you're sort of working normally in the spine. We go from midline to out. Here you're working from out, and you have to be aware of an area they call the Camben's triangle, because that is your sort of working area of how you can address the disc in that area. So you need to assess your Camben's triangle on the MRI. You need to see where this exiting nerve root, as demonstrated by the picture right at the bottom on the left. Some nerve roots are lying very low and you can't get into that area using a scope. So it requires quite meticulous pre-operative planning and selection to assess where does this exiting nerve root, which forms basically the hypotenuse of the triangle. The base of the triangle is formed by the superior end plate of the body. And Camben's original description said that the medial side is formed by the theca and the dural sac. However, when you're doing arthroscopic procedures, this has been included to describe the superior articular process of the vertebra at the bottom. Because if you're doing a true discectomy, you don't want to go beyond that articular process, and it's normally hypertrophy and you can't get in them. But the original description of the Camben's triangle was the exiting nerve root, the superior end plate, and medially the neural structures in the thecal sac. However, for endoscopic work, we've now said the medial side is the superior articular facet of that bottom. Looking at how it's done, as you guys are familiar with scopes, there's a working, there's a working channel and a working port, and through this, you need to do everything. So through this, you need to be able to get your tools through there, your light sources through there, everything is through this. It's quite good, quite a steep learning curve, and in our unit, something we don't do, but for you future spine guys, it's something that you need to be aware of. There are some ex-former fellows who are doing it, and they've shown good results with their patient selection. So I just think it's something you need to be aware of, and to see the different tools that are used to get into that disc space or get to that disc. Now, looking at spondylolisthesis, we're not going to go through this. You must know the Wiltshire classification. Just bear in mind, although there's a degenerative column specifically for degenerative spondylolisthesis, all the other conditions can present later in adult life with the sequela of, let's say you get an adult isthmic listhesis, where the patient probably had the pars problem when they were much younger, but it was asymptomatic and only became symptomatic at a later stage. So some of these conditions, it's not that they're not degenerative, it's just that when they start, they can start off as in the younger patient population and not associated with degeneration. But as the patient gets to 50, 60, because of the overall degeneration that's happening, these conditions then become more apparent, okay? But for the purposes of tonight's talk, we're going to look at specifically the degenerative spondylolisthesis. Just quickly looking at the grading, the myogen grading, which is something you must know. Spondyloptosis, grade 5, 100% loss. For the degen, it normally stabilizes, normally grade 1 or grade 2. They normally don't slip all the way forward. Okay, it's normally grade 1 or grade 2. They may display features of instability in motion, but they normally don't progress to go. If you're looking at a grade 3, grade 4, you have to look for other causes, maybe a pars fracture, maybe another reason that's causing a severe slip. Looking at degenerative, it's usually at the L4, L5 level. Now, this is a concept you guys need to understand, that with a degenerative spondylolisthesis, the problem is at the facet joints. So if it's an L4, L5, the facet articulation between L4 and L5 is incompetent, and then the whole vertebral body with its posterior elements slides forward. Okay. That is different for from example, your isthmic. In your isthmic, the fracture happens at the pars, or the lysis happens at your pars. The posterior elements at L4 stay behind, and that then translates to show you that with a degenerative, you have two things that are becoming narrow. Because the whole posterior elements also move forward, it causes the spinal canal to also narrow. But this forward movement also causes the neural foramina to narrow. So this means that you will get both spinal stenosis symptoms, particularly in the lateral recess, and you will also get foraminal stenosis symptoms, particularly for that level. So to give that some context, you've got an L4-5 degeneration with a degenerative spondylolisthesis. The whole L4 is going to move forward on L5. It will then narrow the L4-5 spinal canal and hit the lateral recesses first. In the lateral recess, it will hit the traversing nerve root. But this forward motion also makes the neural foramina smaller. And in this, it will also hit the exiting nerve root. So that's L4. So a degenlisthesis will hit L4 in the foramina, in the neural foramina, and L5 in the lateral recess. Okay, this is very important because this is how you sort of differentiate the two. Also, clinically, Prof. Dan loves to ask this question: what is the difference between the step in a degenlisthesis and an isthmic listhesis? In a degenlisthesis at L4-5, the step that you can palpate at the back is at that same level because L4 has moved in its entirety forward. If it's an isthmic listhesis at L4-5, the posterior elements of L4 stay behind. So the step is only felt above it. So it will only be felt at the L3, L4 because the posterior elements of L4 have stayed behind. However, L4 has moved forward with its body and then subsequently causes L3 to move forward slightly. You guys need to understand that. So in summary, L4-5 degen the step will be at the same level. In an isthmic, the step will be above that level. Another clue to this, look at the spinous processes. On your x-ray, look at, have the spinous process stay behind? Are they in line? Or is there a visible step on the erect x-ray to show you that this is most likely a degenerative process? And also look, where is the step? Is it at the level or is it above that level? Another thing you have to consider when assessing a degenerative listhesis is how much instability is there. We advocate using your flexion extension views, okay? But in our unit, we also say your MRI is done supine, and then your erect x-ray is done erect. So that's already giving you a flexion extension. If there's a marked difference between your supine MRI and your erect x-ray, it's showing you that that area is mobile. Now, they've gone to show that instability, depending on which article you read, some will say more than 4.5 and 11 degrees. Some would say, I think the consensus has now been reached at more than 4 millimeters of translation and more than 10 degrees of angulation. So in this patient, you have to decide, do I need to go stabilize the spine? Do I need to go open the neural foramina? Do I need to go open the spinal canal? And normally with this process, by the time they've got this degenerative spondylolisthesis, they've got all those problems going on. And by the time you see them, they probably most likely need surgery if they're symptomatic. So the surgical strategy for the lumbar spine, you need to identify clear surgical goals. Okay. So firstly, are you going to decompress? Are you going to decompress a specific nerve root? Are you going to address a specific lateral recess stenosis? You know, are you going to address anterior thigh pain? Are you going to stress the leg pain going down? The patients who do the best are the patients who you've told them preoperatively, I'm going to address this only. Because remember, every time we cut them, we cause other types of pain generators. So that's why spine surgery the great spine surgery is the one where you're going for neural compression and you tell your patients you're going to operate for nerve pathology and nerve pain. You're not going to operate for back pain, okay? So how do you achieve this decompression? We've discussed laminectomy, we've discussed laminotomies, okay? But now remember, I've tried to show you with the MRIs that depending on how much of the lateral recess and of the facets I'm going to take away, I may cause instability by doing just a decompression alone. Another way of looking at, will this area become unstable? If you have an effusion, a facet joint effusion, as illustrated by these two MRIs, you can see pointed to by the arrows on both the images is a facet effusion. It's known that a facet effusion of more than 3 millimeters is signifying instability in that area. So you cannot get away with just doing a decompression, because your decompression will probably lead to further instability. And even this instability on its own can be a pain generator, meaning that you can't just address this with just decompression alone. Bearing all that I've said in mind, surgery for back pain only generally has poor outcomes. But there's a very, very narrow spectrum of the patients with instability who, when they stand up, they've got motion in that area. In those instances, a fusion or stabilizing procedure may be of benefit, but in the state service, we generally don't do that. This is when you're stretching your indications. You've got your patient who will be coming to you, you've got a facet fusion, they don't have real neural structural compromise, but they've got ongoing back pain. You can then argue that you are trying to stabilize that segment. But remember, it's a very narrow indication or window for an indication, and it's something that I, at my stage of my career, won't do surgery for just an effusion. That combined with something else will be, because remember, the sequelae and the complications of surgery. We always say in spine, I can always make it 100 times worse. You know, I'm taking you from having just back pain. I can cause you a foot drop. I can cause a lot of things. I can cause a non-union. And more importantly, I know I'm going to cause adjacent segment degeneration by doing a fusion. So the MRI at the bottom is to show you guys the differences between your different levels of neural compression of spinal stenosis that you get. You always need to ask yourself, like looking at that C, if you're looking at that severe stenosis, you have to ask yourself, if I go and decompress this area alone, so remember, decompression is to say you are doing a laminotomy, you're going down next to that facet and doing a partial facetectomy, Another word for it is an undercutting facetectomy. You're going up to clear that lateral recess. But if you are taking more than 30% of that facet joint, you will cause instability. So if you've got a case that you're looking at and you say, for me to address this stenosis, I'm going to have to take away quite a bit of this facet, then you can make a case for doing a fusion. And remember, it's a whole about a ladder. And another patient you have to worry about, you've got a patient with multi-level degeneration, but they've got specifically L3 pain. You can go and attack just that area, and especially for these complex patients with deformities, like a degenerative scoli, combined with a multi-level degeneration, but they come to with a specific radicular type of pain. You will always try in these patients to do the least that you can, because to correct all that other pathology will require quite extensive surgery. And the other things, the patient with multi-level degeneration and a degenerative scoli is normally elderly, may not tolerate your wide and your massive surgery. And in this patient, you have to target and say, I'm going strictly for the L3 decompression. I think L3 is being hit in the lateral recess in this area. I'm going to go and clean up this area and make more space for the nerves. That's all a decompression is. I may decide to add more screws, but even that decision is a very complex one, because you can't do that fixed segment, and then you've got a degen scoli above it. So we always say, in those complex patients, try to do the least that you can. Do a very targeted approach to say, I'm going for L3 and L3 alone. Okay. And in cases where you know you cannot do a decompression alone, then add a fusion. That will bring us to our next part. What type of fusion? Okay. Traditionally, there's been a posterior instrumented fusion, which is your pedicle screws to fuse that. And it's normally you fusing posterior lateral over the transverse processes. However, there's 360 fusions that everyone talks about, and we're going to talk specifically about that in our next coming slides. So this is just to say all our fusion options. Posterolateral is your traditional spinal fusion. That is one way, you know, you just try and you've decompressed by lateral recess, or you've done a laminectomy. That area is going to become unstable. You just want to fuse that area. You don't want to scratch out the disc, or you don't want to deal with any disc problems in the front. And you want to fuse, and your posterolateral fusion, you're trying to fuse onto transverse processes. If you've left some pars in, you can put some bone along the pars there, because you've done your laminectomy, but you've left your pars, you've left some bony surface to add fusion. So what you can do there, you can put autograft, you can put allograft, we put DVM, you can put bone chips, okay? Or you can fuse from the front. And specifically in the front, you're talking about your A-lifts, your anterior lumbar interbody fusion. If you're doing front alone, it's described for dealing with specifically L4-5 and L5-S1. Front alone allows you to restore disc height. Okay, by destroying disc height, you are opening up the foraminal stenosis. So you are alleviating foraminal stenosis. You're opening up those foramina by increasing the disc height. You're clearing out all that disc, so you can also remove any compression of the spinal canal. It's a very slick operation in that you've got an access surgeon who does the work to get you to, and the spine surgeon only puts in, clears out, does the discectomy, and puts in the cage or whatever fusion device you're going from anterior. The reason for using an access surgeon is in that area you've got iliac vessels, you've got, if anything goes wrong, you need someone who can repair. And the biggest problem that happens in that area, or the most severe complication, is you get vessel injury with massive bleeding and even death. So you want an access surgeon there if you're going from anterior. Also requires extensive planning so you can see where your vessels lie. Are they calcified? Will you be able to move them? Must you work within the bifurcation? Must you work outside and move the vessels to the side? So let the axis surgeon do that, and then you just go in and do your anterior lumbar interbody fusion. Now, circumferential 360. This is the workhorse of the modern spinal surgeon. Circumferential, you are saying posterior lateral. You've got some on the posterior elements with your pars that's left, and then you've got your anterior interbody. The TLIF has revolutionized this because it's allowed you to go via a transforaminal approach and get to the disc, okay? The K-lift is a Camben's approach. That's how it is literally described. You go into that Camben triangle, okay? It allows you to also address all those type of issues to get into the interbody area. So remember, where you've got a patient where, one, you worry about fusion, two, you want to address some foraminal height issues, three, you want to correct some sagittal alignment. A TLIF is a wonderful option because it allows you to attack the spine around all the dimensions, so in the 360 plane. A PLIF came before the TLIF. That's going straight midline. And as you can imagine, a PLIF, you have to move the thecal sac to the left and to the right. Now, by moving those neural elements, there's a lot of complications. You have to translate, the thecal sac too far medially and laterally, and that on its own has got a lot of morbidity to the neural elements. So a lot of people don't do a direct posterior lumbar interbody fusion. We like the TLIF or the K-lift, and in our institution, the TLIF is what we do. The X-lift and the D-lift, they're all different terms. So extreme lateral, direct lateral, oblique, they're just showing you from where you go, where you're going in from the side, and there's different type of cages and devices that you are using to get an interbody fusion. So these are just all the little tricks that you can use to get fusion because you're trying to basically fuse that segment. Okay. Now, looking at the TLIF, I'm going to spend some time describing to what we do. We like it, as I said, and it allows you to address multiple pathologies at the same time. It allows you to decompress the canal and the foramina. You can get indirect decompression of the other side. So we always ask our TLIF patients, which side is the most painful? Because that is the side we're going to go in from. Or if you've got a degen scoli, you'll say you're going to go in from that side because that's the side you want to jack up and sort of get back into coronal alignment. It allows you to restore disc height, and it adds another fusion surface. So looking at the pictures that we've got there, it's showing you how you approach the insertion of the cage into the TLIF, into the interbody space. So you're going transforaminal. In our unit, we prefer to open up all the posterior elements, and you can see the exiting nerve root, you can see everything, so you don't damage anything. And then you swing in the cage from an oblique area entry, and then as you're going in more, you then flip the cage, and you want the cage to sit as far anterior as possible, because then at some stage you want to then restore lumbar lordosis. So this is something you must know about, because I remember there was an exam a couple of years ago where they asked the guys, and they asked you, tell us what a TLIF is, and some institutions didn't know what it was because they haven't seen it, but you guys are lucky, you'll see a lot of them as you come through spines. So looking at fusion complications, pseudoarthrosis or non-union. We're trying our best to create a union. But if that area doesn't unite, you've got a sequela of things that can happen. You get screw loosening, you get ongoing pain, you get rod fracture, instrumentation failure. So we always say we work very hard to get a fusion. And when you're doing a T-lift, for example, you want to clear as much of that disc as possible and get end plate to end plate bleeding or like exposed end plates to allow a better bone-to-bone fusion. So what we'll do, the cage itself has got an opening where you can put graft in, and we'll also pack bone graft into the posterior aspect of that intervertebral space to promote fusion. So you want to get as much of that disc out to allow for your fusion to occur. Also, I mean, you'll see there's cases where guys have gone in, but they haven't put in the posterolateral fusion. Routinely, what we like to do, as you're putting in your screws, you should nibble your transverse processes just to decorticate them. Some people will use burrs to further allow you to decorticate the transverse process, because that's another fusion surface. Okay, so you try your hardest to ensure that the patient fuses, because if they don't fuse, the sequelae are devastating. Now, this is a concept I talked about earlier. They say that once a spinal patient, always a spinal patient. If I fuse that area, the advantages of fusion are plenty. As for the other reasons we spoke about, the T-lift, I decrease all pain generators from that segment. I stabilize that area and I allow all pain generators to settle. However, by fusing that area, I'm increasing the load to the adjacent segments. If I'm fusing L4, L5, I'm increasing the load that L3, L4 has to take, that disc. So this will mean that there will be adjacent segment degeneration. How long it will take, it's variable with patients. Between 5 to 10 years, you expect to see some adjacent segment degeneration. And remember, adjacent segment degeneration, if it's present on its own, if it's asymptomatic, you can just watch. Once it progresses to disease, that means it's now symptomatic, then you have to act. And I know that's why we try to avoid fusions in young patients. We try our hardest to avoid fusions, because you know you're trying to get, as with the hip, whatever, you're trying to get as much out of your construct as possible. Okay. Other complications of fusions, we've talked about the posterior approach and the direct midline and the violation of the soft tissue damage. But just know with your A-lifts and your anterior work, you've got, apart from abdominal complications, you've got, you can cause vascular injury, you can cause visceral injury, and you can also cause retrograde ejaculation. And in men, they won't like it because you're moving all those structures, you move them forward, you actually see everything coming, and by that continued prolonged pressure, you can get the syndrome of retrograde ejaculation. Also, depending on where you put your retractors, etc., you can also get that lumbar plexus can be damaged as it's coming down in the psoas. So, I mean, as with all surgery, you just have to be aware of your complications, and you have to pick the surgical strategy that works best. And I'll emphasize this again because it's the last time I need to mention it. History, clinical findings, then deciding the surgical level that you're going to address. How are you going to address the surgical level in terms of, are you just going to do a discectomy? Or do you need to fuse? Or do you need to do a T-lift? Most guys will ask, why don't you just do a T-lift for everyone? Because a T-lift, I'm adding, looking at the thecal sac, I'm adding the mobility of probing around the thecal sac. I'm adding the epidural bleeding, which can be quite massive and difficult to stop. And I'm adding scratching around in that disc. We know some people have gone through the disc and hit iliac vessels, so you're adding quite a lot of mobility. So you have to know and have good indications for doing a T-lift. This is just a case, one of the cases that I did just to show you. It's our last couple of slides. So if you can see on the X-ray and the AP, she's got marked spondylosis. However, she's also got L3-4. There's a focal degen scoliosis, it's more collapsed down on the left than it is on the right. So she's got a degen scoliosis. If you're looking at the MRI, she's got multi-level areas of canal stenosis, as demonstrated by the 2 axial cuts at different levels. So she's got a lot of things going on with her. If this patient came in with just, for example, L3, L4 problems, we could attack just the L3, L4. But if they come with multiple symptoms of multi-level nerve root compression, then you decide you have to go in. And in this type of patient, what can you do that will address everything? T-lifts, multiple T-lifts. They will allow you to restore her lumbar lordosis. They will allow you to restore the disc height at all those levels. They will allow you to restore the sagittal profile and restore the coronal imbalance as well. So just to talk to you guys through how we do the T-lift. As with any spinal surgery, you want to instrument first, because you don't want to cause instability, but you can't get in screws. So all spinal surgery starts with getting in pedicle screws. Once the pedicle screws are in, you then expose the full neural elements. In this case, because we wanted to address everything, we exposed both sides. We exposed, you can see the thecal sac is running down the middle. You can see the little nerve roots coming out under those screws there. Because remember, the screws are in the pedicle, and as I told you in the beginning, how it looks when you look at it from this view, it's pedicle, nerve root, and then disc space underneath. So there are some cases in the T-lift, let's say the patient has got unilateral disc where you don't have to open the other hemi side. So you can only do a hemilaminectomy. So you open one side and the side where you're going to put the T-lift in from. So that's a patient who doesn't have bilateral pathology, or it's a patient that you can get to the other side without exposing that side. So let's say they've got a left-sided, or you're planning a left-sided T-lift. You can then say you're going to do an undercutting facetectomy on the right side without exposing the whole midline structures and without exposing the other lamina. But in this case, because we were doing a big restoration, we opened up everything. So you can see nerve roots, thecal, you do bilateral facetectomies. The other advantage of doing bilateral facetectomies is it allows you to get more lumbar lordosis when you're compressing down. Then as you can see, that hole on that side is showing you that you're actually getting into that disc. So that hole next to the thecal sac, you're getting into the disc via a sort of transforaminal approach. And that's the area you're aiming for. You then put in your interbody cage and bone graft, and then you put bone graft posterior lateral some guys forget to put posterior lateral bone graft, but always remember to put this in. So this is a radical case because you're trying to restore a lot of things and you want to see all your neural structures. And you can see, with this case, you've managed to restore sagittal parameters. So your midline is almost 90, that's 88.2. And you restore the lumbar lordosis to be within 10 degrees of the pelvic incidence. So remember, your lumbar lordosis from L1 to the top of S1 has to be within 10 degrees, either more or less than your pelvic incidence. So you need to measure your pelvic incidence, but that's another talk for another day. I mean, you guys don't need to know all of that. You'll learn more about PI and all those parameters when you get to spines. For this talk, purpose of this talk is just to give you an overview of what we see with lumbar degenerative spine, all the pathologies that we can address surgically, all our surgical options that we have, and I hope it's been sufficient to answer all your practical questions. I'll be opening up now for any questions. Let's just stop sharing.